Welcome to Concussion Talk Podcast. I'm Nick Mercer, and before I talk to my guest, my good friend Dr. Kristian Goulet, who is a pediatric sports medicine and concussion specialist, about his practice and also about the paper he wrote along with colleague Dr. Suzanne Beno entitled Sport-Related Concussion and Body Checking in Children and Youth, Evaluation Management and Policy Implications. So we will talk about that. If you didn't understand me, then you'll hear it again from during the interview. But first, I want to thank my sponsor, HeadCheck Health. HeadCheck Health bridges gaps in concussion care through simple, powerful technology. Join organizations like the Canadian Football League, Track Factory Racing, the Canadian Junior Hockey League, Eastern Washington University, and Volleyball Canada rely on HeadCheck to improve communications and optimize care. Visit hedgehealth.com for more. And thank you again to HeadCheck Health for being my sponsor for the past 3 years now, and they've been great, so please check them out. And also, to support this podcast, you can subscribe, rate, review, wherever you get your podcasts, Apple, Spotify, Stitcher, YouTube. I'm probably missing something. I'm missing a lot. I shoot on the ones. And also, please check out to help support the show. Check out the advertisers on my website, concussiontalk.com. And thank you so much. Without further ado, here is my interview with Dr. Kristian Goulet. Okay, I'm with Dr. Kristian Goulet now. He's a pediatric sports concussion specialist. Is that adequate? Is that enough? Is that right to say? Or
Yeah, I'm a pediatrician first, and I did a sports medicine fellowship years ago in Boston, and so I do a lot of pediatrics, a lot of head injury, a lot of mental health in Ottawa, Canada.
great. Well, that's exactly why he's here. Not to mention he's a good friend of mine from university, and we hadn't talked. We were just talking briefly before we started recording that last time he was on was episode 2, and my first guest, the first podcast has been me, and so there's been 148 episodes of Concussion Talk podcast, plus all the other ones I've done, but 140 episodes. And this episode 150 now, so it's been a while
Amazing.
since we've had a concussion chat. Although you're here you're in St. John's in 2017, the very concussion conference. I forget exactly what it was about.
Yeah, I was doing a talk for Hockey Canada about
Right, that's what it was.
Yeah, we went out for dinner. I remember that.
Yeah.
It was, at that restaurant used to be a bank. Remember that?
Yeah, Merchant Tavern. Yeah.
Yeah.
Yeah. It's a big tavern. Not tavern. It's a nice spot. It's like, yeah, there used to be Bank of Montreal, I think.
Yeah. But no, you've done amazing things since that first interview years and years ago. And so congratulations to you and all your success.
Thanks.
Definitely want to get some of that Concussion Talk swag. I'll order some later after our video chat.
Thanks. Appreciate that. That's awesome. And I guess so you were. I'll just chat about your first few Ottawa. I lived in Ottawa for a bit when Goulet wasn't there. I'll call him Goulet, bit of a habit, but it's Dr. Kristian Goulet for everyone else. But
Goulet's fine.
You were in Ottawa when I was there. You were at school or doing a fellowship, but or working elsewhere. But where do you work in Ottawa now?
So in Ottawa, I'm in. I work with the University of Ottawa Brain and Mind Research Institute. I do a lot of work with the Canadian Paediatric Society, hence this paper, and I work in the community and with children and affiliated with the Children's Hospital of Eastern Ontario. My main clinic is out in Canada, which is about 15 minutes outside of Ottawa.
That's your hometown. When Karen and I were on our bike trip, we stayed at Eagle for one night there in Canada. We brought from Kingston to Canada, and then we stopped by early. Your parents gave us a great barbecue of burgers and or what else, fries, those
Yeah,
corn.
I had forgotten about that. Yeah,
Yeah,
yeah, that was amazing.
and Nick and Courtney came over and we chatted, we chatted for it, and then we drove. We that night went to that bar near. It's all changed now, but there's a O'Reilly's or some of that, or like I forget. No, I forget. I
Uh,
think my shirt's in my journal somewhere.
oh, that was a different life, eh?
Yes, it
Different
was
life.
a different list. But now this life, I was wanted to talk to you about this. Okay, it's not a scientific article. It's a policy position statement for the
Yeah,
pediatric CBA, Canadian Pediatric, Canadian Pediatric, CPS, Canadian Pediatric Society. It's
yeah.
called. The title is sport related concussion and body checking. I'll slow down. I get excited and I speak quickly. Sport related concussion and body checking in children and youth, evaluation, management, and policy implications. So you basically want to know about how to treat, manage children, manage youth, not children. Say you because I know 18-year-olds and 17-year-olds get offended if I call them children, but that's what the label is. So how to manage concussions in youth and what do you think are the main? I read the paper and I read the abstract. Anyone can read the paper and the abstract is all fully there on the website on the Canadian Pediatric Society website, so they can find that. But what do you think are the main takeaways from your paper? What you've researched beforehand? So.
Yeah, so it was this was sorry, it was many years in the making, this paper. So the Canadian Pediatric Society, they are kind of like the godfathers of pediatric health in this country. And the last time they wrote a position paper on concussions and head injury was way back in 2013. And as we all know, the landscape in concussion research has changed dramatically, in the
Yeah.
last years or so. With the Canadian Pediatric Society, I work on the injury prevention committee, and it was tasked with us is to every 10 years for a lot of different topics we have to re-up, right? And so they asked me to kind of take the reins of this. And so the American Academy of Pediatrics a few years ago had updated their policy, and at the time, for concussions, the body contact age, in 2013, we said, kind of at least pee-wee age, and years and years ago.
Peewee is what, 12, 13?
Yeah, yeah.
Okay.
Yeah, and so body contact around that age, and then the Americans, they started reviewing the data a few years ago and said, well, geez, a lot of injuries can be prevented by taking out some of the body contact.
Yeah.
And when I started, like, medicine 15 years ago, I thought, I was of the other camp, and I thought that, yeah, the earlier you introduce body contact, the more you learn, how to take a check and how to give a check. And but over the course of 15 years, I've definitely, had my mind change. And
Yeah.
so this is it's a very polarizing topic, as you know, Nick, with
In Canada, yes.
yeah, like
Yeah.
but even with body contact, but even with concussions as a whole, I think that
Yeah. Yeah. Jesus.
you have those two different camps. There's such a dichotomy between the two. There's and I think you always have to have a very healthy respect for concussions, that some people don't have. And I think that you have to have an open mind. I always say that when you approach a topic, it's best to be have a mindset of an experimenter, of a scientist, and not of a lawyer. A lawyer knows the outcome of the case, and they try to find
Yeah.
proof to support their notions, whereas a researcher gathers all the applicable information, and then they make a decision. And I think the more you look through the literature about body contact, um, and and what we'll talk about more here is the hockey side of things. Like the literature couldn't be, more definitive that as soon as you introduce body contact, injury rates go up, concussion rates go up, and conversely, when they have made some changes in body contact age, you could see like how the body contact, how eliminating the body contact has done wonders in terms of decreasing injury rates, in kids in hockey.
Yeah, no, I think it's in the States, like there's been I think even I don't know, say Brett Favre, but like some big name athletes have said that they don't want their children playing contact football. They want their children playing, say, like flag football. It's just no, they think contact football below, say, below or period age or below is not needed. So, and I think it'd be great to have some big name hockey player say something similar. It's been like there's not just seems to hockey to be a bit behind the NFL. The NFL, even though in the States it seems that the NFL is so big, so huge there that
yeah, it's monstrous, and they
yeah.
I mean they have so much sway and power, and
Yeah.
I think you see the tackle, football. You see these little clips here and there too of these little 7-year-olds getting
Yeah.
thrown to the ground, and I'm like, well, I do believe in the resiliency of our brains, and
Yeah.
can do wonders in terms of recovery, but every hit like that, I mean,
Yeah.
it's it can add up, and it can have significant impacts. And then so you look at the purpose of contact in sport, and I think the one side of the argument, and I do agree, I do see a point where their body contact, and body checking, I do think that they do hold a place, in the sport. It's just, to what level. And I think that the
Yeah.
amount of contact that you can limit, is going to be obviously key. The less body contact, the less body checking that you have, is obviously the better, but it does, at some stage have a role, in hockey. And the question is, where can we limit the amount of body contact? I think one way that you limit body contact is, obviously in practice. I think you can teach techniques with body contact, but to have full-fledged body checking in practice isn't very reasonable. I think the longer you can delay introducing body checking to a degree is better. Wait for these bodies to physically mature, and you look at the differences, in kids in their growth and development. A 13-year-old, some 13-year-old kids, they haven't gone through that big growth spurt yet. It's like, completely different than some of the other 13-year-olds that can be like, a foot taller and,
Yeah.
30 heavier, and to put these guys and say go at it and hit each other. I mean, that's putting some kids at a great disadvantage.
Yeah.
And I think the other thing that we had mentioned in that paper is how integral is body checking in non-competitive leagues, what we call the non-elite leagues, so the house league. Do you really need body checking at that age? Does it really change is it needed for the outcomes of the games? Is it needed? Does it taking it out, does it really change the nature of the non-competitive games? And again, there's some good studies coming out of there, saying that, well, if you do limit body checking to the more elite competitive leagues and at the higher age levels, 15 above, then you can do well by a lot of these players and limit the amount of concussions and injuries that they get.
Yeah, exactly. That's because I mean we kind of talking about mitigation more than the prevention, because prevention is, as you know, basically impossible. I mean, I don't say impossible is bad word to use, but like it's in prevention. You're not going to stop concussions from happening because, as you said, the 80 to 90% of TBIs, I mean, it's mentioned in the paper, are concussion, and
Yeah.
to prevent concussion just in general life, the concussions will happen, and the balance about they're now one of the important aspects now are also mitigation, of course, but diagnosis, prevention, and treatment. So, which one do you think they're all? Sorry, obviously all equal. I was going to say that, but like, to talk about diagnosis, we think the major steps toward better diagnosis of children, of youth playing would think the best way of diagnosing these conditions are.
Great question. So, well, I think, yeah, you look at it in those different aspects, right? So, ideally, concussions don't happen, but we know, concussions are going to happen, right? They can happen with sports, happen outside of sports. So you do want to limit the concussions as best you can. You might, we got some dogs barking in the background.
I can't hear them.
Oh, you can't? Oh, perfect. So yeah. So yeah, they're right.
They're right. They can't hear them.
Okay. So yeah, so first is prevention, and I think one of the biggest things is increasing awareness, right? And that has people like you, Nick, that have been really increasing awareness, and really throughout society. There's 15 years ago, it's night and day about awareness in terms of concussions. We made some great strides there, and I think it's continuing to bring it to awareness. Sorry, hold on one sec.
I'll fix this, and I'll just leave this section. So you're talking about prevention.
So yeah, so awareness, I think it has gone. It's the improvements in awareness has been amazing. I think like when we were younger, Nick, too, when we were playing our sports in high school and everything, like it's night and day since where it was. So again, I think that's the first step, is just increasing awareness, which has been wonderful. And then the next stage is diagnosing, and I think we've made a lot of strides there. And it's an inexact science, as there's no blood work, there's no brain imaging that we can really do at this point to diagnose concussion. So you're left trying to correlate symptoms with a head injury. And I think that we talked about the awareness of head injury in the general population, and I think the awareness of concussions and how to diagnose concussions with health professionals have come a long way as well. So in Canada, actually, there's a great resource too. So for all professionals, kind of working with concussions, it's called the Paediatric Living Guidelines, and it's the only guidelines that I know.
There are links to this in your paper.
Yeah, exactly.
Yeah.
So there's the link there, and so now with that paper too, it's only online content, but they're just doing kind of the translation component. So the paper, the print copy should be out within the next few weeks or so. So that's a great resource. It's continually updated, which most guidelines you print them and then they're not updated, so they can be out of date very, very quickly. But this one, papers come in, so I regularly get emails with new papers for me to review that we can use to include in the guidelines. So it's really, really up to date. So the diagnosis of concussion, it's not the easiest thing, because as there's so many things that can go into diagnosing or so many things that go into creating concussion symptoms, right? And in terms of, you get hit to the head, but some people have pre-existing headache issues, pre-existing sleep issues, sometimes stress plays into it. So it's not easy to diagnose concussions. So my advice is always to err on the side of caution. So Jamie Kissick, really leader in concussion work. He unfortunately passed away just within the last month or two, but I believe he coined the saying, when in doubt, sit them out. So what I find is, you do a lot of the kids that have some of the most difficult time recovering from a head injury are the ones that not that first concussion, but they go back, they're hiding their symptoms, or they're not aware that perhaps the concussion has started, and they take that second hit, and that second hit is where a lot of the sequelae comes from. So always, when in doubt, sit them out, whether you're a trainer, a physician, the coach. If there is a risk of concussion, pull them out, because that second hit is often the one that does the most damage. And then, the treatment obviously is incredibly important. And this is where people such as myself, we kind of specialize. I've probably seen 8,000, I've treated 8,000 concussions in my life, 8,000 and counting. And no two concussions are really the same. When I treat concussions, I think it's, I take the mindset that there's very, very, even though they all kind of fall under the umbrella of traumatic brain injury, they're very, very different in terms of, when you talk about mild traumatic brain injury, a typical concussion. When you talk about somebody suffering, from a second impact, when you talk about somebody with what we don't say post-concussion syndrome really much, we talk about persistent symptoms.
You mentioned the persistent post-concussion symptoms. Persistent post-concussion symptoms. Yes. Sorry.
Yeah, and so that, and those are, what's going on in the brain with those patients, it's much different than, a typical quote unquote, concussion. And then you get into the whole chronic traumatic encephalopathy population, which again is much different than a concussion and much better than second impact patients and much different than, the persistent post-concussion symptoms. And then you have the people with, the moderate and severe brain injuries, which again, there's similarities with concussions, but again, from a pathophysiological perspective, they're very, very different too. So it's definitely not easy treating head injury patients, just because it's such a variable contributor out there.
Yeah, no, I've noticed by talking to people a lot, talking to a lot of policy people who suffer concussions and or treat concussions, or have the technology to assist with the either mitigation or the treatment of concussions. They all look at different symptoms than what I see is like my main issues that I had a severe brain injury, and whatever I see is my significant problems are they're similar to concussion, but they don't match up exactly. I see. And
exactly.
Yeah. But you're saying about the diagnosis and the second effect syndrome. So that also comes with the second effect syndrome. Tells you as far as we know now, is just make sure you wait long enough that you're fully healed. But like, there's no definite way to know what they're fully healed unless obviously the wait doesn't run time that we can say that chances are very good that you must be healed now. You feel good and you waited a month or whatever, 2 weeks or whatever. And
that's great. Yeah, we don't know when that brain is finally healed, right? And that's the problem. So we go through the guidelines, we go through the return to learn and then the return to play, knowing that there is healing that has to happen in the brain even after the symptoms are gone, to limit the potential of repeat injury. So some people think that as soon as the symptoms are gone, they're good to go, and that's not necessarily the case, and it's not the case.
Which actually kind of made me wonder with this one. Read their paper, the 100S100B blood biomarkers. So do you think blood biomarkers are legitimately think they'll be, or is that more of a just could potentially be like it's a kind of a we'd like to eventually get there, but we're not there yet.
Well, it's interesting, right? So the blood biomarkers. So whenever you're talking about doing any sort of test, right, you want the two measures you look at is how sensitive is the test, right? Meaning that, all right, if you're doing a test to make sure you diagnose something, you want to make sure that you're not missing cases, right? So that's the sensitivity. And then you want to look at the specificity of the test. So if you get a positive result on a test, you want to make sure that positive test is actually due to the thing that you're looking at. So if you get a positive biomarker, you want to make darn sure that biomarker is due to the head injury. Yeah. Now, the problem is with some of the biomarkers is, and I do think there are some that are showing promise for sure. But the problem is, and where my kind of training and my practice is kind of transitioned is looking at neuroinflammation, right? And so what some of these biomarkers are measuring is looking for neuroinflammation. Now, does the head injury lead to neuroinflammation? 150,000% yes. But
Yeah.
there are other things, though, too, that lead to
Yeah.
neuroinflammation as well. And can that blood, the blood biomarker, can that differentiate the neuroinflammation that comes from head injury versus neuroinflammation that comes from, being in pain? Pain causes inflammation,
Yeah.
stress causes inflammation, right? So, sometimes even dietary changes, right, can change neuroinflammation. So, it's tricky. And I think what it can do is it can give you an idea that, all right, that this brain is not 100% recovered. This brain isn't fit to go back. So I do think it definitely has a place, but it definitely, I think, needs some fine tuning before widespread implementation of this.
Yeah, because like, as you're saying, even you can't really get a baseline first. They can't say take someone's blood one day and say, okay, that's your baseline because you're fine, but you don't know. Maybe they have a slight headache. Maybe they changed what they eat. Maybe they ate something last night that was
Yeah.
unsettling or so. It's
Yeah.
hard to say. So, and I said the reason they didn't mention anything about really touch on treatment so much is that who knows? I mean, there's so many different forms, different models of treatment that are possible that we don't know. I mean, one brain injury to the next, as we were saying, it's so different that you may need physio, you may need OT, you may need eye, like see on how to get surgery, but who knows? I mean, just so many that we'd be in here for hours.
So yeah, so the treatment is kind of where we step in, and I think you do look at you do look at patients and where are they? Are they the patient with the concussion? Could there be a second insult going on? Is this somebody with persisting symptoms more than three months, or is this something that's a moderate severe brain injury? So the treatments, because unfortunately there's not really a and I always tell patients when they come to see me that there's no quote unquote medication for concussion, for instance, but this I tell patients, I often say, I work at this place called the Brain and Mind Research Institute. And I think it's important for people to understand that distinction, that the brain and mind are different things, right? The brain's kind of like the hardware, the mind is the software. They work together, but, they're different. And, for the brain to heal, the mind has to be in a good place, right? If the mind is not in a good place, then the brain, it's very, very difficult for the brain to heal. So when I talk about what treatments, I try to, so at the CHEO clinic, when I was running it at the Children's Hospital of Eastern Ontario, we would have lots of fellows and residents and med students come through, and they would walk out of these rooms, before for us to talk about the cases, and they look kind of shell shocked, where we'd see these patients that they've had a head injury a year ago, and they're not in school, and they have chronic headaches every day, and they're kind of like, where do we start? And so my approach with head injury is, all right, so you have your head trauma, and there's lots of things that happen. So one thing that happens with a head trauma is you get a concussion, right? And a concussion, in my opinion, refers to the damage to the neurons that you have in your brain. So when I see patients, I'll draw a neuron for them, and I'll explain what happens to the brain when we get a concussion at the neuron level. And that concussion, and we talk about, all right, well, there's not really anything scientifically proven that we can use to treat this note. But the good news is that your brain has an incredible ability to repair neuroplasticity. And I always say that our brains have been getting concussions for a very, very long time. There is this innate ability to recover after head injury. Now, where we can help, and especially when we see patients who's been suffering from symptoms for 6 months to a year, we say, all right, let's look at some of the other treatables, right? And Nick, you alluded to it there. So I talk about the extracranial issues with a head trauma. So with a head trauma, you get a concussion, but with head trauma, you are going to have some neck involvement, most likely, kind of that whiplash. With head trauma, you can have an injury to your jaw, so you can get temporomandibular joint issue. You can have issues with your inner ear, the vestibular ocular system, right? You can have issues with the eye, the post-traumatic visual stress syndrome. So this is something where we can target, and this is where allied health professionals are key to really help with the rehabilitation. And then you talk about some of the other influencers of head trauma. So one is, you got to make sure you're eating well. You got to make sure you're staying well hydrated, right? So that's important for recovery, whether you have a mild traumatic injury, you're suffering from, chronic traumatic encephalopathy, or you're having persistent post-concussion symptoms. Eating, drinking well is important. We got to make sure that we're not dealing with any other co-founding variables. So if people have been having symptoms for more than 4 to 12 weeks, when they come to see me, I have a very low threshold to get blood work done. And the things that I've been able to diagnose that, people had just assumed, were concussion symptoms, I could write a book, right? Whether it be, low iron, thyroid issues, mono, arthritis, Lyme disease. I mean, there's so many things that can kind of masquerade as concussion symptoms. It's so important for medical doctors to be involved, especially with the chronic patients, to rule out some of these other things. Another thing that I really, really focus on brain recovery is sleep, right? So if we're not sleeping, sleep is like the number 2 cause of headaches, right? If you're not sleeping, your focus is bad. If you're not sleep, we have to get these people back on a regular sleep routine and sleep habit. And then the other thing that we focus on is the mental health side of things. I think head injury has a huge impact on not just the brain, the parts of the brain that control our stress response, but just you look at what happens with head injury and what it does to kids' lives. They have their sport taken away from them, or they their school is suffering from that, and that causes more stress, and it causes pain, and so pain is a major
depression stuff.
Depression, exactly, right? So got to treat the patient holistically, and so that I've kind of developed this approach to treating these really complex concussion patients, and it's actually the similar to the approach that they use for patients suffering from chronic pain. So the first is, we try to get as much information as we can. So before patients come to see me, I have them fill out all these forms, and there's a lot, and it helps, help me get to know the patients, as well as I can. And then, we talk about, all right, do we need to get blood work on this patient? Do we need to do a psychoed assessment? Do we need to do, do we need to get imaging on these patients, right? Trying to get as much information as we can. But the approach that I take is it's this 3P approach. So there are 3 different therapeutic arms. So the psychological treatment, the physio treatments, and then the pharmacologic. And this helps me, kind of organize my thoughts and organize and get a very systematic approach to these patients. So from a psychological perspective, so for everybody, I say you got to make sleep a priority. I say you got to eat as well as you can. So I always tell patients, nobody likes chips and ice cream more than I do, but you can't live on chips and ice cream. And I also say, you don't want to wait for your thirst reflex to kick in, because if you're thirsty, you're already a little bit dehydrated. So you want to have that water bottle handy. And then what I tell with all my patients is, I want you to abide by these 3 rules of 1. So 1 act of physical activity every day, 1 act of mind training, so meditation, mindfulness, right? Just, try to give me 5-10 minutes a day, or at worst, just focus on your breathing 3 times, for 3 breaths a day, or do some yoga. I think that's so important. I'm learning the value of that, not only in my own life, but in, to help patients. And then the other thing is, and this is very, very hard, especially for kids, is limiting what I call the toxic screen time to 1 to 2 hours a day. And so school-based screen time is not toxic. Family-based screen time is not toxic. FaceTiming friends and family is not toxic, but the TikTok, the YouTube, the video games, social media, anything where you're just scrolling, we're learning more and more how detrimental that is, not only on our brain and our mind. And then, sometimes patients with all the change in their lives, dealing with chronic pain, I think sometimes counseling is needed, right? So that's kind of like the psychological perspective. And then from a physiological, that's the next P in this approach. These are kind of your allied health professionals. So, we want to make sure that their eyes get checked. We want to make sure that they're plugged in with the very best physios or occupational therapies, massage therapies. All these things are crucial, for an adequate recovery. A good, highly trained chiropractor. These kind of things these are the people that are going to do the week-to-week appointments that are going to, really push these people people, in that right direction. And then the third P is the pharmacologic. So this is going to be your supplements and your vitamins, and knowing that, there's no real vitamin or supplement or medication that's been shown to, cure a concussion, but there are, lots of different options out there. And it is really trying to, treat the symptoms. So I always say, the mind is not going to be at peace if your pain isn't handled, if you're not sleeping really well, right? If school's not going really well. So, we kind of hijack some of the migraine literature, and we use either supplements or medications, for concussions that have been shown to work with kids with migraines. To be what we considered off-label, but there are some options that are out there that I've used with really good success to either help, calm the mind by controlling pain, helping with sleep, those kind of things. So that's my approach, kind of in a nutshell. I apologize if I ramble too much. My approach.
No, I was gonna say, because like what you said, it was just great, because this is good to give people the more knowledge, because the issues there's some papers about body checking in hockey, which is similar to, say, tackle football. So not the similar, like when you get all the biomechanics and all that stuff, but the same idea of like limiting contact, which is, and also the idea is limiting screen time, limiting those screen time is mental health issues. So it's more societal. Unfortunately, the concussion treatment seems to be very, very societal, as society doesn't want to give up these sports they love, and they don't give up these great gains in the technology that they've gained and stuff, and mental health has just become an issue recently, and so apparently it was an issue for just ignored, and so I think it's just very tricky area to get these kids to be able to say okay, yes, you should management it's very. I'm rambling here, but I encourage people to read Goulet's, and your co-author is Dr.
Yeah, Suzanne Beno. She's at the Sick Kids, and Suzanne did a great job. So the word count for this paper was supposed to be about 3,500 words. The first draft of the paper was almost 14,000 words. Oh. So Suzanne did a great job of helping me kind of whittle it down. But there's definitely a whole lot. What you're seeing with the paper is kind of like the tip of the iceberg.
Exactly. Exactly. So I encourage you to do CPS.ca, which is Canadian Paediatric Society, and search the sport today now. Sport related concussion. I had it there now. I missed that. The screen's kind of funky. Because the title is sport related concussion and body checking in children and youth. Evaluation, management, and policy implications. So although I probably said that slurred a bit, but you get the idea. So search for Goulet and Dr. What's what's their name again? It's Dr. I'll read that to you.
Suzanne Beno, yeah, Beno.
No, Suzanne Beno. So Goulet, Beno, and check out the article. They make there's obviously implications and suggestions there for what the best management, ideal management can be, but doctors can only work with in society. So these issues of mental health, of screen time, of the contact, not collision, non-contact, that's more as a general overall thing that will eventually just take place. It's going to take time, and I hear people are obviously get aggravated when they just don't see a doctor and don't get diagnosed they want, or get diagnosed they don't want, or whatever. But doctors are reacting to in society. So there's only so much treatment they can. It's not a kind of thing. It just fix you. Just you got to work with them and to eat well, sleep well, and to treat these issues seriously if you intend to recover seriously. But if you just want to just do it as part of life and just it's gonna suck, and it's gonna suck for a while, then just accept that. It's obviously, so that's me preaching now for a bit, but I'll try to limit my preaching. I will not limit my appreciation for Dr. Goulet or Dr. Kristian Goulet. Goulet is as I know, and so we said we haven't. This is our first podcasting 148 episodes of Concussion Talk Podcast. So it's kind of fitting that he's out and fitting because who knows when I'll stop doing these podcasts, probably, hopefully, a long while. But I mean,
hopefully keep doing them. Yeah, it's awesome.
Yes. So thank you. So it's been great. I'm catching up with Goulet because I haven't talked to him since 2017. He came after that conference here with Hockey Canada conference here in 2017. So thank you so much, Goulet, and our Dr. Kristian Goulet. And please everyone check out the paper.
Awesome.
The article. So thank you.
Thank you.
I gotta stop this.